Hello everyone and welcome back to a Vital Nursing 101 video. Today we are going to talk about one of the most important medication classes in nursing pharmacology, opioid analgesics. Specifically, we are focusing on morphine, hydromorphone, and oxycodone. These medications are commonly used for moderate to severe pain, especially when pain is not controlled well enough with non-opioid medications like acetaminophen or NSAIDs. But opioids are also high-risk medications. They can be very helpful when used correctly, but they can also cause serious harm, especially respiratory depression, sedation, overdose, constipation, falls, dependence, and misuse. So today, we are going to break this down step by step in a beginner-friendly way. We will talk about why opioids are used, how they work, important side effects, black box warnings, nursing responsibilities, lab monitoring, patient teaching, and what findings should be reported to the provider. And throughout the video, I will add pop test questions to help you think like a nurse. Let's start with the basics. Opioid analgesics are medications used to relieve pain. The word analgesic means pain reliever. Opioids are usually used for moderate to severe pain. They may be used after surgery, after traumatic injury, during severe acute pain episodes, in cancer pain, palliative care, end-of-life care, or other situations where the provider determines that opioid pain control is appropriate. The three medications we are focusing on today are morphine, hydromorphone, and oxycodone. Morphine is a very common opioid used in hospitals. It may be given by mouth, IV, subcutaneous injection, or other routes depending on the form. Hydromorphone is also known by the brand name Dilaudid. It is a strong opioid and is often used for severe pain. It can be given orally or IV depending on the order. Oxycodone is commonly given by mouth. It may be immediate release or extended release. It may also be combined with acetaminophen in medications such as oxycodone acetaminophen. A big nursing school point is that opioids are not all equal in strength. Hydromorphone is more potent than morphine. That means a smaller dose of hydromorphone can have a strong effect. So, as a nurse, you must be very careful with opioid dosing, especially during transitions from one opioid to another. Never assume that 1 milligram of one opioid equals 1 milligram of another opioid. That is not how opioid dosing works. Memory tip: Dilaudid is delicate dosing. Hydromorphone or Dilaudid is powerful, so dosing must be handled carefully. Pop test question: which medication is an opioid analgesic? A. Ibuprofen. B. Acetaminophen. C. Hydromorphone. D. Loratadine. The correct answer is C. Hydromorphone is an opioid analgesic used for moderate to severe pain. Now let's talk about why opioids are used. Opioids are used when pain is moderate to severe and when other medications are not enough, not appropriate, or need to be combined with stronger pain control. For example, a patient who just had abdominal surgery may have severe incisional pain. A patient with a femur fracture may have severe traumatic pain. A patient with advanced cancer may need opioids for cancer-related pain. A patient receiving comfort care may need opioids to relieve pain and sometimes severe air hunger or dyspnea, depending on the clinical situation and provider order. Opioids can be part of what is called multimodal pain management. Multimodal pain management means using more than one type of pain control strategy. For example, a post-op patient may receive scheduled acetaminophen, an NSAID if appropriate, ice packs, positioning, splinting, and an opioid for breakthrough pain. Breakthrough pain means pain that breaks through the regular pain control plan. The goal is not always to remove pain completely. The goal is to reduce pain enough so the patient can function, breathe deeply, cough, move safely, sleep, and participate in recovery. For example, after surgery, uncontrolled pain can prevent a patient from taking deep breaths or walking. That can increase the risk of complications like atelectasis, pneumonia, and blood clots. So pain control matters, but safety matters too. That is why nurses must balance pain relief with sedation level, respiratory status, fall risk, and overall patient condition. Pop test question: a patient had surgery and reports severe pain that prevents deep breathing and ambulation. Why is pain control important? A. Pain control only makes the patient happier. B. Pain control can help the patient breathe, cough, move, and recover. C. Pain should never be treated after surgery. D. Pain medications have no risks. The correct answer is B. Pain control supports recovery by helping the patient breathe deeply, cough, move, and rest. Now let's talk about how opioids work. Opioids work by binding to opioid receptors in the central nervous system. The central nervous system includes the brain and spinal cord. The main receptor you will hear about is the Mu receptor. You can think of the Mu receptor as one of the main opioid receptor sites involved in pain relief. When opioids bind to these receptors, they change how the brain and spinal cord perceive pain. They do not necessarily fix the cause of the pain. Instead, they change the patient's pain experience. So if a patient has a surgical incision, morphine does not heal the incision. It decreases the pain signal and changes how the body responds to that pain. But opioid receptors are not only involved in pain, they are also involved in breathing, alertness, digestion, and reward pathways. That explains many opioid side effects. Because opioids affect the brainstem respiratory centers, they can slow breathing. Because they affect the central nervous system, they can cause sedation and confusion. Because they affect the gastrointestinal tract, they can slow bowel movement and cause constipation. Because they affect reward pathways, they can contribute to misuse, dependence, and addiction. Memory tip: opioids slow. They can slow pain signals, but they can also slow breathing, slow thinking, and slow the bowels. That is one of the best ways to remember opioid side effects. Pop test question: opioids relieve pain mainly by acting on receptors in which system? A. Central nervous system. B. Urinary system only. C. Integumentary system only. D. Endocrine system only. The correct answer is A. Opioids act mainly on opioid receptors in the brain and spinal cord to change pain perception. Now let's compare morphine, hydromorphone, and oxycodone. Morphine is often considered a classic opioid. You may see it used in acute pain, postoperative pain, severe pain, cancer pain, or palliative care. Morphine can cause hypotension, especially when given IV, because it may cause histamine release and vasodilation. Vasodilation means the blood vessels relax and widen, which can lower blood pressure. Morphine can also cause itching, nausea, vomiting, constipation, sedation, and respiratory depression. Hydromorphone, or Dilaudid, is stronger than morphine. It is often used for severe pain. Because hydromorphone is potent, dosing errors can be dangerous. Small doses can have strong effects. This is why nurses must be careful with decimal points and medication concentration. For example, 0.2 milligrams and 2 milligrams are very different doses. That decimal point matters. Oxycodone is commonly used orally. It may be used for moderate to severe pain. It may come alone or in combination with acetaminophen. Combination products are very important for nursing safety. If a patient is taking oxycodone acetaminophen, also known by some brand names like Percocet, the nurse must monitor the total daily acetaminophen dose. Why? Because too much acetaminophen can cause liver toxicity. So with oxycodone acetaminophen, you are thinking about both opioid safety and acetaminophen safety. Memory tip: Oxy plus APAP means watch the liver map. APAP means acetaminophen. Pop test question: a patient has an order for oxycodone acetaminophen. What should the nurse monitor in addition to opioid effects? A. Total daily acetaminophen intake. B. Eye color. C. Height. D. Hair texture. The correct answer is A. Combination opioid products may contain acetaminophen, so the nurse must track the total acetaminophen dose. Now let's talk about major side effects. The most serious opioid side effect is respiratory depression. Respiratory depression means breathing becomes too slow, too shallow, or ineffective. This can lead to low oxygen levels, respiratory arrest, coma, and death. This is why nurses always assess respiratory rate, oxygen saturation, sedation level, and overall mental status before and after opioid administration. A respiratory rate of 8 breaths per minute in a sedated patient after opioid administration is not something to ignore. A patient who is difficult to arouse after receiving an opioid is not just sleepy. That can be a sign of opioid toxicity. Sedation usually happens before respiratory depression. That is a big nursing point. If a patient is becoming more and more sedated, that can be an early warning sign that respiratory depression may follow. So do not only count respirations. Also assess level of consciousness. Can the patient stay awake? Can they answer questions? Are they slurring words? Are they drifting off mid-sentence? Are they hard to arouse? Memory tip: sedation before respiration. Increasing sedation may come before dangerous respiratory depression. Pop test question: which assessment finding is most concerning after IV hydromorphone? A. Pain decreased from 9 out of 10 to 5 out of 10. B. Patient is difficult to arouse and breathing 7 times per minute. C. Patient asks for water. D. Patient says the room is cold. The correct answer is B. A difficult to arouse patient with a respiratory rate of 7 may be experiencing opioid-induced respiratory depression. Now let's talk about other common side effects. Opioids commonly cause constipation. This is extremely important. Opioid constipation can be severe and does not always improve with time. Why does it happen? Opioids slow movement in the gastrointestinal tract. That means stool moves more slowly through the intestines, more water is absorbed, and stool becomes harder. As a nurse, you should assess bowel sounds, last bowel movement, abdominal distension, nausea, vomiting, and whether the patient is passing gas. Many patients on opioids need a bowel regimen. A bowel regimen may include stool softeners, stimulant laxatives, fluids, fiber if appropriate, and mobility when safe. Do not wait until the patient is severely constipated. Think prevention. Another common side effect is nausea and vomiting. Opioids can trigger the vomiting center in the brain and slow gastric emptying. Patients may need antiemetics as ordered. Opioids can also cause itching. Itching may happen with morphine because of histamine release. Opioids can cause urinary retention. That means the patient may have difficulty urinating or may not empty the bladder completely. This is especially important after surgery and in older male patients with prostate enlargement. Opioids can also cause hypotension, dizziness, and falls. This is why fall precautions are important. A patient may feel okay lying down, but when they stand up, they may become dizzy. Teach them to call for help before getting up. Pop test question: which side effects should the nurse try to prevent in a patient taking opioids regularly? A. Constipation. B. Hair growth. C. Increased appetite only. D. Improved vision. The correct answer is A. Constipation is a common opioid side effect, and prevention is very important. Now let's talk about black box warnings and major safety warnings. Opioid analgesics carry serious boxed warnings. These warnings include addiction, abuse, and misuse, which can lead to overdose and death. They include serious life-threatening or fatal respiratory depression. They include accidental ingestion, especially by children, which can be fatal. They include neonatal opioid withdrawal syndrome when opioids are used for a prolonged period during pregnancy. They include risks from combining opioids with benzodiazepines, alcohol, or other central nervous system depressants. Let's explain that. Benzodiazepines are medications like lorazepam, alprazolam, diazepam, and clonazepam. They can cause sedation and slow the central nervous system. Alcohol and sleep medications can also depress the central nervous system. When opioids are combined with these substances, the risk of extreme sedation, respiratory depression, coma, and death increases. This is a major test point. Opioid plus benzodiazepine equals high respiratory risk. Memory tip: opioids plus benzos can stop breathing. Also, extended release or long-acting opioids have special safety concerns. They should not be crushed, chewed, or split unless the specific medication instructions allow it. Crushing an extended release opioid can release too much medication at once. That can cause overdose. Pop test question: which combination is especially dangerous because of increased risk of sedation and respiratory depression? A. Opioid plus benzodiazepine. B. Opioid plus water. C. Opioid plus stool softener. D. Opioid plus a meal. The correct answer is A. Opioids combined with benzodiazepines can cause extreme sedation, respiratory depression, coma, and death. Now let's talk about nursing responsibilities before giving an opioid. Before giving morphine, hydromorphone, or oxycodone, assess the patient's pain. Use a pain scale. Ask about location, quality, severity, duration, and what makes the pain better or worse. But do not stop there. Also assess respiratory status. Check respiratory rate, depth, oxygen saturation, and lung sounds if needed. Assess sedation level. Is the patient alert, drowsy, confused, difficult to arouse? Assess blood pressure and heart rate. Opioids can lower blood pressure, especially IV opioids, and especially in patients who are volume depleted or medically fragile. Assess allergies. Ask about previous reactions to opioids. It is also helpful to clarify the difference between side effects and true allergy. For example, nausea from morphine is a side effect, not necessarily an allergy. But hives, swelling, trouble breathing, or anaphylaxis would be more concerning for allergy. Assess opioid tolerance. Is this patient opioid naive or opioid tolerant? Opioid naive means the patient does not regularly take opioids. These patients are at higher risk for sedation and respiratory depression when opioids are started. Opioid tolerant means the patient regularly takes opioids and may require different dosing. This is provider managed, but nurses should understand the concept. Assess kidney and liver function. Many opioids or their metabolites are affected by kidney or liver function. Morphine metabolites can accumulate in renal impairment, increasing the risk of sedation and respiratory depression. Hydromorphone also requires caution in renal impairment. Oxycodone is affected by liver metabolism and kidney excretion. So if a patient has kidney or liver disease, opioid effects can be stronger or last longer. Also review other medications. Look for benzodiazepines, sedatives, sleep medications, muscle relaxants, alcohol use, antipsychotics, or other CNS depressants. Also check when the last opioid dose was given. Do not stack doses too close together. Pop test question. Before giving IV morphine, which assessment is most important? A. Respiratory rate and sedation level. B. Hair color. C. Shoe size. D. Favorite food. The correct answer is A. Respiratory rate and sedation level are critical before giving opioids. Now let's talk about safe administration. Always follow the medication rights. Right patient, right medication, right dose, right route, right time, right reason, right assessment, right documentation, right response, and right education. Opioids are controlled substances, so they require careful handling and documentation. Follow facility policy for wasting medication with a witness when needed. Double-check high alert or high-risk opioid doses according to policy. Be especially careful with IV opioids. IV opioids act quickly. That means side effects can also happen quickly. Give IV opioids as ordered and according to facility policy. Do not push faster than recommended. Monitor the patient after administration. For oral opioids like oxycodone, onset is slower than IV medication, but respiratory depression and sedation can still happen. For extended-release opioids, remember they are not for quick relief of sudden pain. Immediate-release opioids are usually used for acute or breakthrough pain. Extended-release opioids are usually used for around-the-clock pain management in patients who are already opioid tolerant, depending on the specific medication and order. Do not crush extended-release tablets. This can cause dose dumping, meaning too much drug releases at once. That can lead to overdose. Pop test question. Why should extended-release oxycodone not be crushed? A. It may release too much medication at once and cause overdose. B. It makes the medication taste bad only. C. It turns it into an antibiotic. D. It prevents constipation. The correct answer is A. Crushing extended-release opioids can cause dangerous rapid release of the medication. Now let's talk about reassessment after giving an opioid. After giving an opioid, reassess pain. Did the pain improve? Can the patient move, cough, deep breathe, or rest more comfortably? Also reassess sedation level and respiratory status. This is not optional. A patient can have improved pain but unsafe breathing. For IV opioids, reassessment usually happens sooner because onset is faster. For oral opioids, reassessment may happen later. Always follow facility policy. Assess blood pressure because hypotension can occur. Assess for nausea, vomiting, itching, dizziness, and urinary retention. Assess fall risk. A patient who just received morphine or hydromorphone should not get up alone. Teach them to use the call light. Document the medication given, pain score before and after, sedation level if required, respiratory assessment, and any side effects. Pop test question. After giving oxycodone, which reassessment is most important? A. Pain relief, sedation level, and respiratory status. B. Hair texture. C. Eye color. D. The patient's favorite TV show. The correct answer is A. The nurse must reassess both effectiveness and safety. Now let's talk about naloxone. Naloxone is the opioid reversal medication. You may know it by the brand name Narcan. Naloxone is used when opioid toxicity or overdose is suspected. It can reverse respiratory depression caused by opioids. Signs of opioid overdose may include very slow breathing, shallow breathing, stopped breathing, extreme sleepiness, inability to wake up, pinpoint pupils, low oxygen saturation, cyanosis, low blood pressure, or slow heart rate. Pinpoint pupils are very small pupils. Not every patient will have every sign, so do not wait for all symptoms before taking action. If the patient is not breathing adequately, support airway and breathing, call for help, and follow emergency protocols. Naloxone may be given IV, IM, subcutaneous, or intranasal depending on the situation and what is available. One important nursing point: naloxone can wear off before the opioid wears off. That means respiratory depression can return. So after naloxone is given, the patient still needs monitoring. Another important point: naloxone can cause acute withdrawal symptoms in patients who are physically dependent on opioids. They may wake up suddenly with agitation, nausea, vomiting, sweating, anxiety, pain, rapid heart rate, or high blood pressure. This can be scary, but airway and breathing come first. Pop test question: what medication reverses opioid-induced respiratory depression? A. N-acetylcysteine. B. Naloxone. C. Vitamin K. D. Protamine sulfate. The correct answer is B. Naloxone reverses opioid effects and is used for suspected opioid overdose or severe respiratory depression. Now let's talk about lab monitoring. For opioids, there is no single routine lab like an INR for warfarin, but labs still matter depending on the patient. Monitor kidney function, especially BUN, creatinine, and eGFR. This is important because opioid metabolites may accumulate in kidney impairment, especially with morphine. Monitor liver function tests if the patient has liver disease or is taking medications metabolized by the liver. These labs may include AST, ALT, bilirubin, and others depending on the situation. For oxycodone-acetaminophen combination products, monitor total acetaminophen dose and liver safety. If there is concern for acetaminophen toxicity, the provider may order acetaminophen levels and liver labs. Monitor oxygen saturation, but remember that oxygen saturation does not replace respiratory assessment. A patient receiving supplemental oxygen may have a normal oxygen saturation while still breathing too slowly, so count respirations and assess sedation. In some higher-risk settings, capnography may be used. Capnography measures exhaled carbon dioxide and can help detect hypoventilation earlier, but availability depends on the setting. Also monitor bowel function. This is not exactly a lab, but it is a key clinical monitoring point. Ask about last bowel movement. Assess for constipation. Monitor intake and output, especially if urinary retention is a concern. Pop test question: a patient on oxygen after surgery has an oxygen saturation of 96%, but is very sedated and breathing 6 times per minute after morphine. What should the nurse do? A. Ignore it because oxygen saturation is normal. B. Recognize possible opioid-induced respiratory depression and take action. C. Give another dose of morphine. D. Turn off the monitor. The correct answer is B. Oxygen saturation can look okay with supplemental oxygen, but a respiratory rate of 6 with sedation is dangerous. Now let's talk about patient teaching. Teach patients to take opioids exactly as prescribed. They should not take extra doses or take doses more often than ordered. They should not mix opioids with alcohol, benzodiazepines, sleep medications, or other sedatives unless their provider specifically says it is safe. Teach them not to drive, operate heavy machinery, or make important decisions until they know how the medication affects them. Opioids can cause drowsiness, dizziness, and slowed reaction time. Teach patients to change positions slowly. This helps reduce dizziness and falls. Teach them to call for help before getting out of bed in the hospital. Teach about constipation. This is very important. Patients should increase fluids and fiber if appropriate, move as tolerated, and use stool softeners or laxatives if ordered. They should report no bowel movement, severe constipation, abdominal swelling, vomiting, or inability to pass gas. Teach them not to crush, chew, or split extended-release opioids. Teach safe storage. Opioids should be stored securely and away from children, pets, visitors, and anyone for whom they were not prescribed. Teach safe disposal. Unused opioids should be disposed of according to pharmacy, community takeback, or FDA disposal guidance. Do not keep old opioid prescriptions just in case. Teach patients that sharing opioids is dangerous and illegal. Teach them and caregivers about overdose signs. These include slow breathing, extreme sleepiness, inability to wake up, blue lips, or limp body. Many patients prescribed opioids may also receive naloxone or be taught where to get it. Teach caregivers how to use naloxone if prescribed or available. Pop test question. Which patient statement shows correct teaching? A. I can drink alcohol with oxycodone if I take it at night. B. I should not drive until I know how this opioid affects me. C. I can share leftover pills with a friend who has pain. D. Constipation never happens with opioids. The correct answer is B. Patients should avoid driving or unsafe activities until they know how opioids affect them. Now let's talk about what findings should be reported to the provider. Report respiratory depression. This includes slow breathing, shallow breathing, pauses in breathing, low oxygen saturation, or difficulty breathing. Report excessive sedation. If the patient is difficult to arouse, confused, unusually drowsy, or unable to stay awake, report it. Report hypotension, especially if symptomatic. Symptoms may include dizziness, fainting, weakness, or lightheadedness. Report uncontrolled pain. If the patient's pain remains severe despite medication, the provider may need to reassess the cause of pain or adjust the pain plan. Report new or worsening confusion, especially in older adults. Report signs of allergic reaction. This includes hives, swelling of the face or throat, wheezing, or trouble breathing. Report severe nausea or vomiting that prevents oral intake. Report urinary retention. For example, a patient has not urinated after surgery and has bladder distension. Report severe constipation, abdominal distension, vomiting, or inability to pass gas. Those may suggest ileus or obstruction. Report signs of misuse or unsafe use. For example, taking more than prescribed, using someone else's medication, or combining opioids with alcohol or sedatives. Report if the patient is receiving multiple CNS depressants. Report concerns about medication safety, especially with hydromorphone dosing or extended-release opioid forms. Pop test question. Which finding should be reported immediately? A. Patient reports pain improved. B. Patient is difficult to arouse after opioid administration. C. Patient asks when lunch arrives. D. Patient says the medication label is hard to read. The correct answer is B. Difficulty arousing a patient after opioid administration may indicate dangerous sedation and possible respiratory depression. Now let's walk through a clinical scenario. You are caring for Mr. Davis, a 56-year-old patient after abdominal surgery. He rates his pain as 8 out of 10. The provider ordered morphine IV as needed for severe pain. Before giving the morphine, you assess his respiratory rate. It is 16 breaths per minute. His oxygen saturation is 97% on room air. He is awake and answering questions appropriately. His blood pressure is stable. You give the morphine as ordered. After administration, you reassess his pain and safety. His pain is now 4 out of 10, which is improved. But he is very sleepy and keeps drifting off while talking. His respiratory rate is now 9. What should you do? You should not ignore this. You should stimulate the patient, reassess airway and breathing, follow your facility protocol, notify the provider or rapid response if needed, and be prepared for naloxone depending on the patient's condition and orders. This scenario shows a key nursing concept. Pain relief does not automatically mean the medication response is safe. You must reassess both pain and respiratory status. Let's do another scenario. You are caring for Ms. Lee, who is prescribed oxycodone acetaminophen for pain. She says, I also took some Tylenol from my purse because my pain was bad. What should you think? You should think about duplicate acetaminophen. Oxycodone acetaminophen already contains acetaminophen. If she adds extra Tylenol, she may exceed the safe daily acetaminophen limit and increase the risk of liver injury. As the nurse, you should assess how much she took, when she took it, notify the provider if needed, and teach her not to combine acetaminophen-containing products without checking first. Let's do one more scenario. You are caring for a patient receiving hydromorphone IV. The order says hydromorphone 0.2 milligrams IV. You pull the medication and notice the syringe concentration could easily lead to a dosing error. What should you do? Pause. Verify the dose. Use the medication administration system. Follow facility policy. Ask another nurse to verify if required. Never rush with opioids, especially hydromorphone. Hydromorphone is potent, and decimal errors can be dangerous. Remember, 0.2 milligrams is not the same as 2 milligrams. Now let's review the big nursing school points. Opioids are used for moderate to severe pain. Morphine, hydromorphone, and oxycodone are opioid analgesics. They work by binding to opioid receptors in the brain and spinal cord, changing pain perception. They do not fix the cause of pain. They can cause respiratory depression, sedation, constipation, nausea, vomiting, itching, urinary retention, hypotension, falls, dependence, misuse, and overdose. Respiratory depression is the most serious side effect. Sedation may come before respiratory depression. Always assess pain, respiratory rate, oxygen saturation, sedation level, blood pressure, allergies, kidney and liver function, opioid tolerance, and other CNS depressants. Do not combine opioids with alcohol, benzodiazepines, or sedatives unless specifically directed by the provider. Monitor bowel function and prevent constipation. Teach patients not to drive until they know how the medication affects them. Teach safe storage and disposal. Teach not to share medication. Naloxone reverses opioid overdose. After naloxone, continue monitoring because the opioid may last longer than naloxone. For oxycodone acetaminophen, monitor total acetaminophen intake. For extended-release opioids, do not crush, chew, or split. For hydromorphone, be extra careful with dosing. Memory tip: opioids slow. They slow pain signals, but they can also slow breathing, slow thinking, and slow the bowels. Now let's finish with 5 true or false review questions. Question 1, true or false? Opioid analgesics are commonly used for moderate to severe pain. The correct answer is true. Rationale: opioids such as morphine, hydromorphone, and oxycodone are used when pain is moderate to severe and other pain control options are not enough or not appropriate. Question 2, true or false? Respiratory depression is one of the most serious opioid side effects. The correct answer is true. Rationale: opioids can slow breathing, which may lead to respiratory arrest, coma, or death if not recognized and treated quickly. Question 3, true or false? A patient who is very sedated after receiving an opioid should simply be allowed to sleep. The correct answer is false. Rationale: excessive sedation can be an early warning sign of opioid toxicity and may occur before respiratory depression. The nurse should reassess the patient and take action. Question 4, true or false? Naloxone is used to reverse opioid overdose or opioid-induced respiratory depression. The correct answer is true. Rationale: naloxone, also called Narcan, blocks opioid effects and can reverse opioid-induced respiratory depression. The patient must still be monitored because naloxone may wear off before the opioid does. Question 5, true or false? It is safe to crush extended-release oxycodone if the patient has trouble swallowing. The correct answer is false. Rationale: extended-release opioids should not be crushed, chewed, or split unless specifically allowed by the medication instructions. Crushing them can release too much medication at once and cause overdose. And that is your beginner-friendly nursing pharmacology review of opioid analgesics: morphine, hydromorphone, and oxycodone. Remember, opioids can be very helpful for serious pain, but they require careful nursing assessment and monitoring. Always think: pain relief, respiratory rate, sedation level, blood pressure, bowel function, fall risk, and patient teaching. And when you hear opioid, remember, opioids slow. They slow pain signals, but they can also slow breathing, slow thinking, and slow the bowels. As a nurse, your job is to give pain medication safely, monitor the patient closely, teach clearly, and report concerning findings early. Thank you for watching, and I'll see you in the next nursing pharmacology lesson.